How are prices currently set on the prostheses list?
Yeah, so look, there are a number of historical prices and categories on the prosthesis list that, were established a number of years ago, particularly in categories that, and there are a number of categories on it that cover certain things, whether it be hip implants or the kind of nuts and bolts that you put into the body and so forth. Many of them were benchmark prices that were set a number of years ago, and any new products that come in, there's no reassessment of those prices, so they just get coded according to what was already there. And as you know, for generic technology, over a period of time, you'd expect the price to decline based on either volume or what's happening in other markets and so forth. But there is no dynamic mechanism that's been put in place for the prosthesis list. So in fact, now for a number of those categories, we've ended up with prices that are between 20 and 40% higher than most other comparable economies around the world.
It seems that reform is inevitable, and it seems that the vast majority of stakeholder groups that there needs to be acknowledge the need for some kind of reform. You've put forward the idea of DRGs. Can you explain what they are and how they would operate?
So what this is basically a bundled payment that the health funds would make based on the nature of a particular treatment episode or a procedure. So there would be a bundle of standard things that we would pay for a hip replacement, for example. And then if something were to go wrong and the doctor was to document it, or something different was to happen, the doctor was to document it in the case notes, we would be able to make extra payments. But the principle is that you make a bundled payment based on the procedure, not what we do at the moment, which is where we have a set fee that can be claimed for each item on the prosthesis list. So it's not just the main implant that you pay the item for, it's all of the accessories that surround that implant, whether they be plates, screws, hemostats, skin closure stuff and so forth. And the growth in the volume of those accessories over the last 5 years has greatly exceeded the growth in the volume of the actual primary device.
And how would they set the value of that group? So the reimbursement value of that group for that procedure.
So look, it's something that is already done by the Independent Hospitals Pricing Authority in Australia, and we've made some suggestions about how they could do this for medical devices across the board by using some price points from the public system, but also from some of the data we've collected around the world from comparable economies as well. So there'd be a combination of some international and local prices, but it's important to remember with the public hospital system in Australia that often there are a range of prices that are created for a particular treatment, for a particular intervention. Some, they might be 5% of a certain item is used for one particular type of surgery, which, is very complex, but the majority of items that are used in that area are actually priced much lower. So really what you need is a weighted average price for each procedure. And it's the Independent Hospitals Pricing Authority that would go about getting that data. Now, I know I have heard that a number of stakeholders feel that this is going too far too fast. So one alternative might be to retain the prosthesis list for the main primary implants, like your hip or your knee implant, but for all the accessory items to bundle them up into a consumables bundle and actually price that. And that is an area that we're looking at very carefully, because that gets you out of this excessive volume growth kind of problem that we've had with some of the accessories that are used in each procedure.
You see a role for health technology assessment. So HTA is used very extensively for PBS decision making in other parts of the health system. Do you see a role for that, or for MSAC, or the application of processes and decision making frameworks that are used in other parts of the health system, like pharmaceuticals?
Oh, absolutely. And I think there's been a bit of a myth in the health professions that has taken hold, that because surgery it's very difficult to do randomised controlled trials in surgery, that you don't really need this. But I think, over the years we've had, and particularly in Australia with the National Joint Replacement Registry. We've really shown that surgical research to collect data for health technology assessment is an extremely valuable part of what we do in terms of both delivering safe and effective care, but also in terms of managing health costs as well. So of the all of the categories on the prosthesis list, there are about 305 categories where they're, for all intents and purposes, generic. There are about 56 categories where there is a difference in outcome, and that's measurable by things like the National Joint Replacement Registry, that shows that, you know, the performance of some devices is much better than others, you know, in terms of things like revisions and people having to have repeat surgery. Now, at the moment, that data is not used in pricing, and we think it's time that it should be used in pricing. You mentioned MSAC, and certainly for brand new technologies, that has a very important role. It's not the majority, but we have seen some genuine breakthrough innovation in the last few years. One of the things has been the introduction of minimally invasive heart valve surgery. And the department, in fact, did an excellent job at the health technology evaluation of the transcutaneous aortic valve, and the mechanisms for new technology are pretty good. We're also seeing a lot of computer-guided and robotic surgical options being introduced. So much of traditional medtech innovation has been around making life easier for the surgeon and making the device more usable for the surgeon, but that may or may not translate into a different patient outcome. And it's a patient outcome that we are looking at to measure and to fund differently with HTA. So it's a bit of a nuance, but it's a nuance that's very important in the medtech world.
How do you respond to the criticism that the change or DRGs could potentially lessen choice, increase out-of-pocket costs, and ultimately undermine the product that your members provide?
Well, look, I think that, you know, predominantly, if you look at any of the research that we've done over many years, what our members need firstly is an affordable premium. I mean, there is no market if people can't afford private health insurance. And, you know, the wait lists in the public system around Australia have been absolutely smashed as a result of COVID-19. And so it's not, you know, necessarily correct to say, okay, well, we could do all of the elective surgery in the public system, because that just won't happen. So we have to actually have viable gold hospital cover for there to be a decent market here. And I think that's one objective really that we all share. But we've created a set of principles for negotiating the reform, and top among those principles is that clinician choice would be retained. That is in our very detailed proposal that we've put to the department, that if a doctor wants to use something outside the bundle, so long as they document it, they can use whatever they like and will pay for it. But it needs to be documented.
Do you believe that we should anticipate something from the government in the upcoming budget?
Absolutely. It is a necessity for us to be able to continue to deliver a better result in the next premium round coming up later this year. And as I mentioned to you before, there are communities all around Australia that are desperately concerned about the blowout in wait times for common surgical procedures like hips, knees and cataracts.
Rachel, I wanted to ask you about off-label use and particularly the funding of off-label use through the PL.
One of the problems with the prosthesis list has been that off-label use is not well documented or evidence-based, and that is the root cause of the issues with the use of hernia mesh in pelvic organ prolapse, which has been a major scandal in Australia. And I think one of the things that we're pushing very hard for is for a proper framework around off-label use in medical devices, which starts with the TGA and a proper tracking mechanism and a proper clinical trials framework around the use of some of these things.
Dr. Rachel David, thank you for joining us today.
Thanks, Paul. It's always great to talk to you.